Hello there, I am Dr. Camacho. In this video, I will talk to you about tonsillectomy. Here we see little Jimmy, and Jimmy is snoring. He's tired. His mother is concerned. He's struggling at school. You can see he's fallen asleep. The teacher says he does not pay attention. His friends are worried because he doesn't like to play like he used to. Here you see him with his brother who also snores. It kind of runs in the family. They're both tired. Jimmy goes to see his physician and he gets referred to a surgeon. Here you can see an ear, nose, and throat surgeon taking a look into Jimmy's throat. His history includes snoring, bedwetting. He's been snoring for several years. His mother says that she also sees him stop breathing. He has pauses with choking and gasping. You look into Jimmy's throat and you can see that he has big tonsils. I'm outlining the tonsils here with red. And these tonsils are likely obstructing his airway. If Jimmy had little tonsils, as shown in A, then a sleep study would actually be helpful because we're not sure exactly whether or not Jimmy has sleep apnea or just snoring. However, in Jimmy's case, his tonsils are huge, as shown here in D, and that tiny airway can easily get obstructed during sleep. When the airway is obstructed during sleep, you get snoring, and in some cases, the child may have pauses in breathing, gasping, bedwetting. They're tired during the day, and they have a classic story. And if it matches up to where the story is classic for sleep apnea and the child has very large tonsils, the surgeon may offer a tonsillectomy and adenoidectomy. If the child is young, say 3 years and under, sometimes the surgeons may require a sleep study even if the tonsils are enlarged. In some cases, the sleep improvement is temporary, meaning they may have improvement in sleep symptoms for a few years, and then the problems happen again. Often, if that is the case, then the ear, nose, and throat surgeon or the pediatrician will order a sleep study. If a child is going to have a sleep study, especially after failing a tonsillectomy or having a recurrence of sleep apnea after a tonsillectomy, then the sleep center will put EEG monitoring, meaning brainwave monitoring, a bunch of stickers that they put on the forehead, on the scalp, and then they'll put stickers around the eyes called an electrooculogram, and oxygen monitors and sensors, belts around the chest and abdomen, to monitor whether the child is trying to breathe, and that will tell us if the child has sleep apnea. During a sleep study, an apnea-hypopnea index of 1 or more means a child has sleep apnea. There are 3 types of blockage during sleep. The first is snoring. Snoring means that the palate or the tonsils are narrowing the airway, and as the tissue vibrates, it causes the snoring sound that we're used to. The second type of blockage is hypopnea. Hypopnea is when you get more blockage than the snoring, and it either causes the oxygen to drop by 3% or it causes the brain to wake up. The third type is an apnea. An apnea is when the airway is blocked 90% or more. And for children, we look at 2 breath cycles, meaning the child is breathing normally, and all of a sudden, for what would have been 2 breath cycles, they stop breathing or have the decreased airflow. And this is different from adults. In adults, you need 10 seconds for pause. In children, it's 2 breath cycles. So how is a tonsillectomy performed? What's involved? The procedure is performed in an operating room. The child will be fully asleep. In order to make sure the child does not have problems, typically we're going to ask nothing to eat after midnight. Younger children, it all depends on the provider, may sometimes allow a little sip of water or juice depending on what time it's taken and the age of the child. But to be safe, most of the time, nothing to eat after midnight. That way the stomach is empty. If the stomach is full during the anesthesia process, the child may vomit and then aspirate, meaning that the vomit goes into the airway and can cause pneumonia and other breathing problems. Once a child is in the operating room, parents sometimes may be allowed to come into the operating room with a child. It all depends on the provider and the situation or scenario, how much anxiety the child has, the age of the child, and they're going to put a mask over the face. The mask provides anesthetic. Once the child is asleep, usually the parents will leave the room, and then an intravenous line is placed, an IV line is placed, and the patient is then intubated. Here we see in green, there's a breathing tube. The breathing tube goes into the airway. As surgeons, we will then use an instrument to open the mouth. We then use a tool to grab the tonsil. You can see it right there. And another tool to remove the tonsils. We usually will start on the top part on one side or the other, grab the tonsil, pull it toward the middle, and then we use this tool here. This one specifically is a bovie, and the bovie has metal on the tip, and as the tonsil is removed, starting from top to bottom, we make sure to cauterize all the little vessels. There are several small blood vessels, and we take great care to make sure that we stop bleeding as we're going. As I mentioned before, the adenoidectomy is typically performed as part of the procedure. The adenoids sit in the back part of the nose. We also remove them through the mouth. You can see here the mouth is open, and we typically will use a mirror to see the back part of the nose, and that allows us to remove the adenoids through the mouth. The other procedure that we sometimes will perform is called a turbinoplasty. These shown here are the turbinates, and the one that we might shrink during this procedure is this bottom one. It's called the inferior turbinate. In this case, we're using what's called the radiofrequency ablation, but we can also do a microdebrider. But the goal is to shrink the turbinates and then push them off to the side with the goal of improving the airway. Here we can see a drug-induced sleep endoscopy. We typically perform this as a second procedure. Usually if we're thinking about doing a tongue-based reduction, this is often done for kids who have failed the tonsillectomy and adenoidectomy, or they did well for a while and then years later the obstructive sleep apnea recurs. We might do this procedure first before reducing the size of the base of the tongue. And you can see in Jimmy's case, after the surgery, he is sleeping much better. He and his mom are happy, and his airway is now much bigger. You can see it back here. The tonsils are gone. He's breathing much better. And as we look further, you can see that the space is dramatically improved. Where the tonsils were here on the sides, the tissue is now gone, and instead of having the tonsil tissue, you can see that it is scarred in, and that scar tissue holds the airway open and also prevents the sides from collapsing in. Remember, this is what tonsils can look like in some people. Does having a tonsillectomy affect your immune system? Temporarily it does, because the tonsil tissue shown here, this is called mucosal associated lymphoid tissue, and that means that the tonsils are sampling bacteria and viruses. They come in through these little holes. The body sees the viruses and bacteria, and because we have what are called white blood cells, those white blood cells will help release antibodies. They've done studies to see whether or not the immune system goes down. It does go down temporarily for only about 3 months. And because Jimmy's brother also has a problem, he additionally had a tonsillectomy, and now he and Jimmy can both stay awake, and they are both doing well in school, and the family is very happy. Only a healthcare professional who examines you or your loved one can provide you specific health education and information based on your physical exam or your loved one's physical exam. I am Dr. Camacho. Thank you for watching.